Hi everyone, I want to talk about pulmonary embolism. But before you can enjoy this presentation, kindly check out my presentations on venous thromboembolism, which includes DVT and pulmonary embolism. I have two separate videos on venous thromboembolism, the pathogenesis, the diagnosis, risk factors, and I made separate presentation on treatment of DVT and prevention of venous thromboembolism. So about 4 videos out before this one, and if you check all those 4, then you have no trouble grasping everything that I'm about to mention here. Okay, thank you. Let's go. An acute pulmonary embolism is a venous thromboembolism that kills very fast. Diagnosing pulmonary embolism is mostly equivocal because there is no fixed pattern of presentation and loss of non-specific features. It means that there is an embolus blocking the pulmonary artery. We're having this. The pathogenesis is essentially that of Virchow's triad that consists of stasis, damage to endothelium, and hypercoagulable state. And that will be the main formation of the vein thrombosis. When the thrombus breaks, fragments or emboli will travel upwards depending on whether it is distal DVT or proximal DVT. If it is distal, it will travel upwards through inferior vena cava, and if it is proximal, it will travel down from superior vena cava, either inferior or superior vena cava. They will both empty at the right atrium, and from the right atrium to the right ventricle, and from right ventricle to pulmonary artery. You can see why that emboli will cause trouble, while the fragments from the DVT distal and proximal coming from either superior or inferior vena cava to the right atrium and right ventricle will cause trouble in the lungs because they will go or empty into the pulmonary artery. What are the terms that we are likely going to come across when it comes to pulmonary embolism? It could be acute. Acute pulmonary embolism, the symptoms will be immediate, and that will be after pulmonary vessels obstruction immediately. If it is subacute, that is going to take some days or weeks after the event. And if you hear something like chronic pulmonary embolism, that means pulmonary hypertension over many years. And of course, it will be slowly formed. If you hear something like high risk or massive pulmonary embolism, then the individual is hemodynamically unstable. But if it is immediate risk or submassive pulmonary embolism, it means the individual is hemodynamically stable. And when I talk about hemodynamical stability, I think you understand what I'm talking about. We're talking of blood pressure being within normal range, a pulse within normal range, not confused, no decreased level of consciousness, and so on and so forth. When you hear something like low risk pulmonary embolism, it means there's no evidence of right ventricular strain here. And Saddle pulmonary embolism means embolus lodges at the bifurcation of the main pulmonary artery, and that will be associated with sudden death within hours. Lobar pulmonary embolism will involve lodging down into the distal part of the main lobe of a particular lobe. Segmental or subsegmental pulmonary embolism will cause pulmonary infarction and pleuritis. Asymptomatic pulmonary embolism is possible when you are just picking the features of pulmonary embolism on your spiral CT pulmonary angiography. That is a contrast enhanced computed tomography. So this person is pretty lucky, okay? No symptoms. You are just doing some routine investigation somehow for another reason, and on spiral CT pulmonary angiography, you are picking the features of pulmonary embolism. Wow, lucky people. What are the possible risk factors here? I'm not going to waste your time going over details of risk factors of pulmonary embolism when I have given a separate presentation on DVT risk factors or venous thromboembolism risk factors. It's the same. Check out my videos on that and you'll get all the risk factors. It's a lot of them. Be vigilant for possible pulmonary embolism in the following people. Okay, just keep an eye because we want to help them. The essence of hospitals, doctors, and nurses is to prevent death. Okay, so under my watch, I will take extra care to look after these people, looking out for pulmonary embolism. It's not that I'm wishing them to have it, but because I don't want them to have it, then I will take extra caution. So keep an eye, okay, on people with malignancy. Watch. Make sure all investigations are done, okay? Pregnant women, yes. Monitoring the fetus, monitoring the mother, watching out for other signs that could trigger DVT and pulmonary embolism. Stroke patients, you know that. Hospitalized patient, particularly intensive care unit, or surgical ward, particular orthopedic surgery, okay, and post-surgery of any sort that confines the patient to bed for a long period of time. How about people with renal disease, particularly those with nephrotic syndrome? I'll keep an eye. How about my patient who might have had spinal cord injury? So, what am I going to do? Extra caution. And of course, I've mentioned post-orthopedic surgery. They are doing that every time. We appreciate them. And the people with inherited thrombophilia. In fact, from the onset, once the diagnosis is made, monitoring, correcting risk factors will start immediately. Then, DVT could be found where? In deep femoral vein, and also in femoral vein or popliteal vein, inferior vena cava, common iliac, external iliac, or internal iliac. Note this. When emboli are obstructing the vascular bed mechanically, we can have altered ventilation and perfusion ratio, and inflammatory process will set in. That will lead to atelectasis, secondary to surfactant dysfunction. And when that is happening, when the part of the lungs or lobe is collapsing, then there will be aposemia with increased ventilation trying to meet up with the requirement. That will lead to decreased carbon dioxide, CO2. And when the acid level is low and alkalinity is high, that's respiratory alkalosis. And subsequently, decreased stroke volume. When there is decreased cardiac output with increased pulmonary vascular resistance and hypoxic vasoconstriction, there will be increased right ventricular dilation with decreased right ventricular flow. That will lead to decreased left ventricular preload and, of course, further decrease in cardiac output. Then hypotension, then decreased tissue perfusion. So that is how the individual might present with hemodynamical instability. And then we know we are dealing with a serious problem here. And if no intervention is done within 72 hours, we might be writing the obituary of the affected individual. Therefore, we need to know what is causing this, and we need to get down to business immediately. It's an acute emergency. Kindly subscribe to my channel. This is not the end of this presentation. I'm still going to present on how you are going to treat this horrible acute respiratory emergency. Thank you.